So now we're ready to look at the lower respiratory tract. This would be continuing from our previous lecture looking at upper respiratory. So we're going to start with the trachea. Now the trachea is lined with ciliated pseudostratified columnar epithelial. The idea again is to produce lots of mucus, and the cilia moving that mucus up, catching all of the dust and pathogens that may have gotten inhaled, and then we can have that can travel up, and then we end up swallowing it. Now what's different with the trachea is you can see all these rings of cartilage that's in the blue here. Those of course have a protective nature to them, so that you hit a blow to the neck then won't cause that trachea to collapse. But again, the cartilage is a C shape, so that means the open side of the C is in the back here, so all along the front and the sides is where you see that cartilage. It's back here where there is no cartilage. And that's because of its association with the esophagus. The esophagus needs to expand when you eat food, so it needs to have some area to expand into. If the trachea was solid cartilage all the way around, then you'd have that trachea kind of popping out in front in order for this the esophagus to expand, and we don't want that. So the esophagus, when it fills up, is just going to push a little bit into the trachea. Of course, not enough to close off the trachea, but enough to give it a little more room for expansion. Now the trachea is going to branch in the mediastinum and then separate into the next structures, and that's the bronchi. Now the bronchi look basically like a tree upside down, so you're going to have a continuing branching pattern that we have seen that you'd see in a tree. So the first structures that branch off the trachea are going to be the primary bronchi. So there's a right and a left primary bronchi. These guys still have C-shaped rings of cartilage to them. The right one you can see is much larger and has a slight steeper angle than the left one does, and that means then that the right one is more likely, if you inhale a marble or something, that's more likely that marble is going to travel down into the right bronchi. The primary bronchi then branch into secondary bronchi. The secondary bronchi are 3 on the right side, 1 for each lobe. There's 2 secondary bronchi for the left lung, since there's only 2 lobes on the left lung. So 1 secondary bronchi for each lobe. Then the secondary bronchi branch into tertiary bronchi, which are the ones in color here. And then you can even go farther into 4th, 5th order, etc., until you get down to finally what are called bronchioles. Now, as far as tissue characteristics that we see with the bronchi, you have in the primary bronchi a lot of cartilage, and then there's less and less cartilage as you move towards the tertiary or even smaller bronchi. However, the smooth muscle amount increases, so less smooth muscle in the primary bronchi, more and more and more as you travel to the tertiary bronchi, which means then we're going to see more control of the diameter of the bronchi in the smaller tertiary bronchi than when we would in the primary bronchi, since there's no smooth muscle, and that thick cartilage is going to stop any kind of constriction of the bronchi. Then there's also a decreasing amount of cilia and mucus producing cells as you move from the primary bronchi down to the tertiary bronchi, which means then by the time you get down to the tertiary bronchi or smaller, since there's not the cilia and the mucus producing cells, we're going to have to rely on macrophages basically to remove any debris from those levels. Now the bronchioles are connected then, of course, to the end of the bronchi. These do not have any cartilage at all, but they do have smooth muscle. And you can see the smooth muscle wrapped around these bronchioles in the pictures down here. That helps control the airflow into different regions of the lungs. And so we can contract those smooth muscles to cause it to constrict, so that would be bronchoconstriction, or we can relax those smooth muscles and cause the bronchiole to dilate, so that would be bronchodilation. Now asthma then is excessive stimulation of that smooth muscle causing bronchoconstriction and therefore making it more difficult to breathe. The bronchioles end with the terminal bronchioles as far as the conducting zone. So so far we've been all in the conducting zone. We're just moving air, no gas transport at all going on. So now we're ready to look at the respiratory zone. Now the respiratory zone, we're just going to continue this branching pattern. So we've got bronchioles here, these terminal bronchioles here, and then the first structures of the respiratory zone is going to be the respiratory bronchioles. And you can identify these because you can see on the side of the respiratory bronchioles alveoli, these air sacs that we see throughout. Now from there we'll continue to branch into alveolar ducts, so that would be located here, small alveolar ducts, and then finally into alveolar sacs, which would be a group, and then the alveoli, which is the individual air sac. So think of the lungs basically as a bunch of very tightly compacted grapes together. So you can see the bronchioles would basically be the stems, and all of the alveoli then are going to be the grapes themselves, and they're tightly packed in. And so the serous membranes that surround the pleural cavity are just basically on the outside of the most distant ones of these groups of alveolar sacs. Next, too, we look at the blood supply that's going on in the in this area, and there's going to be, of course, there's two circulations going on. First, we can look at the branch of the pulmonary artery. So here we're bringing in blood from the heart, and it's traveling then down, of course, into smaller blood vessels like arterioles, and then finally down into the capillaries themselves. And the capillaries then are next to those alveoli, so it can pick up oxygen and then travel through the pulmonary into the branch of the pulmonary vein, and then it's back to the heart with oxygenated blood. But there's also another circulation through the lungs, and that's the bronchial veins and arteries. And so these are here to supply the bronchioles themselves with oxygen. So the bronchial artery actually branches off of the aorta and then travels and then goes and delivers blood and oxygen to the bronchioles and other larger structures within the lungs. Now look at a close-up of the alveoli. So here's one alveoli, here's another, here's another. These alveoli are again packed in very close together. The alveoli are composed of simple squamous epithelial, so it's nice and thin layer of cells that outline the alveoli itself. Now these are also referred to as type 1 cells. So here either simple squamous or type 1 cells. The other type of cell that we find in the alveoli is called a septal cell. The septal cells are in charge of secreting surfactant. We'll get back to what surfactant's used for later. Scattered around the alveoli are going to be macrophages. As I mentioned, since we don't have the cilia and mucus producing cells anymore, we need macrophages to help clean up any debris that happens to be there. Also scattered throughout between the cilia, you can see maybe a little bit here and here, is going to be some elastic fibers to help give some structure and some stretch to the alveoli themselves. And then there's alveoli pores. Those are located here. You can see the pores scattered out throughout. These alveoli pores connect adjacent alveoli, so we can get good airflow between alveoli. They just don't have to connect only to the respiratory bronchioles. And then that provides just alternative routes for air movement. And as far as blood vessels, you can see the capillaries here are in close connection with the alveoli because that's where we're going to have gas exchange taking place. So if we looked at the respiratory membrane, we can see it's composed of lots of different structures here. The respiratory membrane has in its layers first the epithelial cells from the alveoli, so that's the simple squamous epithelium we see here. And then below that is what's called the basal lamina of the alveoli, as well as the basal lamina from the capillary endothelium. And that's just an underlying layer of proteins. in that region. And then finally the endothelial layer here in the orange for the blood capillary. So this is an extremely thin layer. It's only 0.5 microns thick. Put that in perspective. A dime is about a millimeter in thickness. If I took and sliced that dime into 1,000 slices, I'd have a micron. And this is half the thickness of one of those slices. So we're talking a very thin membrane or a thin layer in order for gas movement. And we need that because the gases, the oxygen and the carbon dioxide, are going to be diffusing across that membrane. There's no special transport proteins to move oxygen and carbon dioxide from the alveoli to the blood or vice versa. It's simple diffusion. We need that really thin so that diffusion can take place quickly to move it across without any difficulty. So anything that's going to interfere with the thickness of that respiratory membrane then is going to interfere with the ability to move those gases across. Now looking at the lungs as a whole, we can see here again, as I mentioned, there are 3 lobes to the right lungs, 2 lobes to the left. That's pretty much because the heart kind of pushes into the left side. There's actually an area here that's called the cardiac notch, where the heart pushes in and takes up some of that space. The apex of the lungs is the top portion here. It's labeled over here, but it'd be the top portion, whereas the bottom, the part of it that's lies up against the diaphragm, would be the base. The hilum is this region here that has the openings for the pulmonary arteries and veins and for the primary bronchi to be able to enter. So you can see here's the hilum here. It's sort of an indentation area where all those things enter. And then last, the pulmonary segments. The pulmonary segments are color-coded over here for, here's the right lungs and here's the left lungs. And they're basically, you have a bronchial pulmonary segment for each of the tertiary bronchi. This is basically, there's connective tissue that separates or partitions each of these pulmonary segments, and they're of clinical importance because, first of all, pulmonary diseases tend to be confined to a particular segment. So if you've got emphysema, it tends to be located in one segment. It doesn't typically locate it or spread, in other words, or cross between 2 segments. And then the other is that we can surgically remove a segment without damaging the rest of the lungs because of the fact that connective tissue separates out the different segments. We can just dissect out a segment and try to preserve more lung tissue that way. Now the pulmonary membranes, or the pleural membranes, are of course coverings over the surface of the lungs. As I showed you before, you could see that in a couple slides earlier. Now these pleural membranes again are serous membranes. They're of course going to be divided into parietal and visceral pleura. So you can see here the parietal pleura is glued to the wall of the chest. So over here, we took this picture and blew it up. So the parietal pleural would cover the inside wall of the thoracic cavity. And then the visceral pleural is the layer that covers the lungs itself. And in between the two, of course, then would be the pleural cavity. Now the idea, of course, with the pleural membranes is first, of course, to reduce friction, since the pleural cavity is filled with fluid. As the lungs move to expand, there's a little bit of movement between the chest wall and the lungs, and so the pleural fluid in there would help reduce that friction. An inflammation of the pleura is called pleurisy. It can often result in the membranes becoming roughened. That would increase the friction, and therefore they get pain. And it could increase fluid production, which we can see here on this side, and that's going to end up hindering breathing. The reason it does this is because of the negative pressure that we establish within the pleural cavity. So intrapleural pressure, so inside, intrapleural would refer to inside the pleural cavity, tends to always be about -4 millimeters of mercury lower than the lung pressures itself, so inside the alveoli. And this is basically because of two forces that are working to pull the lungs away from the thoracic wall. And that one is surface tension and compliance, which we'll look at again in a bit and see what those exactly are. And then there's also one force that tends to expand the lungs, or keep the lungs glued to, in a sense glued, but tight up against the parietal pleural layer, or the outside wall of the thoracic cavity, and that's the cohesive properties of water. It's like if you had two wet slides, microscopic slides. If you tried to pull those two slides apart from each other while they're wet, it would really be hard, but you could slide them past each other to get them to separate. But pulling them apart would be really hard. And so that's keeping the lungs expanded and against that thoracic wall. But the recoil of the compliance and the surface tension wants to pull the lungs away from the wall. So these opposing forces end up causing the slight pull away, and that gives that negative pressure. So that negative pressure, having that negative pressure, is what's going to keep the lungs expanded so that they don't collapse. Now let's look and see what this compliance and surface tension stuff's all about. Well, first of all, compliance is, like we've seen this before, is basically how well the lungs expand and contract. So the lower the compliance, the harder it is you have to work to fill the lungs and empty the lungs. So things that can affect compliance are going to include loss of supporting tissues, like the elastin tissues that surround the alveoli, that we see in emphysema. So they lose compliance. They're just not as elastic anymore. Or low levels of surfactant. It also lowers compliance, and we'll see surfactant actually helps to keep the lungs expanded, or the alveoli expanded, so they don't collapse. And then reduce mobility of the thoracic cage, say in arthritis. It's not going to be as easy to move the lungs if your joints are damaged by arthritis or other skeletal disorders. So losing any of this kind of elasticity or ability to expand the lungs and then recoil the lungs is going to be a problem for breathing. So we need the lungs, or basically are going to be highly expanded. We need them to be highly expanded at all times. Now, surface tension is a characteristic of water where you have a stronger attraction between the adjacent water molecules than between the water and gas boundary, which basically means, if you look at this picture here, these water molecules that are up on the surface of the water are more highly attracted to each other than they are to anything in the air above them. So their water molecules like each other. That's why when you drop a drop of water on a table, it forms a little water droplet instead of spreading out flat on the table. That's surface tension at work. What that means for the alveoli then is that water molecules are going to pull at each other and pull towards the middle, and that would result in causing those alveoli to collapse. And of course, then that would mean that every time you inhaled, you had to blow up the alveoli first and then expand them even larger. And that would be way too much work. We want those alveoli to stay expanded. We don't want them collapsing every time we exhale. So we have a substance called surfactant. And surfactant is basically like a detergent. It actually looks very much like phospholipids, and it basically breaks up the surface tension, so that having this surfactant molecule mixed in with the watery layer on the inside of the alveoli means that that's the only tension you get from surface tension is between those molecules, and that's just too small to allow the lungs to collapse. So basically the idea is that surfactant keeps the lungs expanded and prevents the surface tension from increasing and causing our lungs to, or the alveoli to collapse. So that ends our trip down the respiratory tract. We'll move on to some of those disorders and see what happens when we have some problems with diseases associated with that respiratory tract.